Hello, my name is Ikramuddin Ahmed Khan. I will be performing lower extremity joint mobilization as part of the week 5 video assignment for the extremity manipulation course. For this assignment, we have a 35-year-old female police officer who was sideswiped by a car. Patient is status post 8 weeks after this incident. Injury sustained were femoral neck fracture, ACL and MCL ligament tear of the knee, severe high lateral ankle sprain. Patient has undergone open reduction and total fixation of the femur 8 weeks ago and is 1 week status post arthroscopic repair of the ACL at the knee. She has worn the walking boot for 6 weeks and has been off for the past 2 weeks now. Patient complains of 3 out of 10 pain at the hip and knee and 6 out of 10 pain at the ankle. Patient lacks a range of motion, strength of the left lower extremity. She's expected to return to full duty in 3 months. Her extension, hip extension, abduction, internal rotation is reduced by 50%. Knee flexion is reduced by 25%. Patellofemoral joint has reduced medial glides and inferior glides. Ankle dorsiflexion and plantar flexion, eversion, are reduced by 50%.
So for increasing the hip abduction of the hip joint, we will be following the same convex concave rule. I will be gliding the femur inferiorly, but raising the patient's leg over my shoulder to get better leverage. I'll be trying to mobilize the femur in an inferior direction. Grade 3 and grade 4 mobilization will be applied. Grade 3, large amplitude into resistance. Grade 4, small amplitude beyond the point of resistance. For the third part of the mobilization, we will be working on improving the hip internal rotation. Well, we are placing the patient's hip in internal rotation with a knee bent at 90 degrees. It would be better if we have a gait belt on to stabilize the leg. Unfortunately, I don't have one at the moment. So I'll be trying to stabilize the ankle and under my arm and try to move the hip into extension. Grade 3 for level 3 pain, large amplitude oscillations up to the point of resistance. Grade 4, small amplitude beyond the point of resistance. This time we are starting our mobilization with hip extension. As the patient has limitation of hip range of motion by 50%, we'll be gliding the femur anteriorly to improve the hip extension. I will be performing grade 3 mobilization as the patient complains of 3 out of 10 pain. And understanding the convex and concave rule, I'm raising the knee joint a little bit to improve my leverage. I'll be performing 10 mobilizations, which are large amplitude. Moving on to grade 4, which are small amplitude beyond the point of resistance. Progression of hip extension will be the physiological extension, where I'll be placing my hand on the upper part of the femur and using my body as a leverage for improving the extension. So moving on to the knee joint, the patient has a limitation of knee flexion and is reduced by 25%. Pain is 3 out of 10. We will be again performing grade 3 and grade 4 mobilization. Both hands stabilizing the tibia, holding on the crest of tibia. I'll be pushing the tibial plateau inferiorly. Grade 3 mobilization are large amplitude up to the point of resistance. Grade 4, small amplitude beyond the point of resistance. Increasing the patellofemoral range of motion, I will be using the thenar eminence of my right hand and locating the patella and stabilizing the leg in a neutral position and moving the patella in an inferior and performing an inferior glide of the patella. So grade 3 and grade 4 mobilizations are done. Grade 3, large amplitude up to the point of resistance. Grade 4, small amplitude beyond the point of resistance. The medial mobility of the patellofemoral joint, we would be performing a medial glide on the patella, stabilizing the leg in a neutral position, performing a grade 3 mobilization, large amplitude up to the point of resistance, moving to grade 4, small amplitude beyond the point of resistance. Onto the ankle joint. Here, patient complains of 6 out of 10 pain and has lack of range of motion and dorsiflexion. We will be performing grade 1 and grade 2 mobilization to manage pain. Grade 1 mobilization will be small amplitude at the beginning of the range. Following the convex concave rule, I'll be mobilizing the talus, doing some traction before I do that, traction, and then moving the talus posteriorly. We'll do small amplitude. As patient tolerates, we can move on to large amplitude within available range. For improving the plantar flexion of the ankle joint, the patient again had 6 out of 10 pain, and we will be mobilizing the calcaneus and performing an anterior glide, stabilizing the lower leg, the tibia, and we'll be performing an anterior glide. At grade 1 mobilization, we can also perform a traction and do large amplitude at the beginning of the range. Moving on to small amplitude depending on patient tolerance. Large amplitude into available range. For improving the ankle eversion, we will be mobilizing the calcaneus and moving it into a medial direction from the lateral aspect. And again, we are doing grade 1 and grade 2 mobilization, grade 1 being large amplitude at the beginning of the range. And grade 2 being small amplitude within available range.